Welcome to this deep dive into, well, the very common but often really puzzling experience of dizziness.
It really is common, isn't it?
Yeah, and today we've gathered some fascinating insights to try and unpack what might be happening when you feel that spinning or tilting or just, unsteady sensation.
And we'll be looking particularly at likely causes and some of the recent progress in understanding and treating it.
Exactly. So the first challenge, it seems, is just the word dizzy itself.
It's such a catch-all term. One of the first things clinicians try to do is get past that word.
How do they do that?
Well, they often ask you to describe the feeling without using the word dizzy. What does it actually feel like? Is the room moving? Are you moving?
Ah, okay. So trying to get more specific.
Precisely. Because dizzy could mean vertigo, which is that illusion of movement, like spinning.
Right, or it could be more like disequilibrium, feeling off balance.
Exactly, like you might fall, or presyncope, that feeling like you're about to faint.
Oh yeah, that near faint feeling.
And then there's just general lightheadedness, sort of a vague feeling maybe in your head.
So those categories are helpful for diagnosis, I guess.
They are traditionally, but there's also a newer way of looking at it.
Wow.
Yeah, focusing more on the timing and the triggers. When does it happen? What brings it on?
Okay, why the shift?
Because people are often much better at describing, say, it happens when I roll over in bed, than they are at saying, I think this is vertigo versus lightheadedness.
That makes sense. Easier to describe the circumstances.
Right. So this titrate approach, timing, triggers, and then a targeted examination, it's becoming quite influential.
Interesting. Okay, so let's dig into the why.
Yeah.
Why do we get dizzy in the first place? What's the machinery behind balance?
Well, it's incredibly complex, actually. It's not just one thing. Your balance relies on constant input and coordination between your eyes.
What you see.
Yep. Your inner ear, the vestibular system, which senses motion and gravity.
Yeah.
Your brain, which processes all this information, and even sensory nerves like in your feet and spine, telling your brain where your body is in space.
Wow. So it's like a whole network.
Exactly. And if any part of that network gets disrupted, well, that can lead to dizziness.
Okay, so let's break down some common causes. Inner ear problems seem like a big one, especially for that spinning vertigo feeling.
Definitely. And probably the most common cause of vertigo specifically is BPPV.
Benign paroxysmal positional vertigo. That's a mouthful.
It is, but it breaks down nicely. Benign means it's not, life-threatening. Paroxysmal means it happens in sudden, brief spells.
Okay.
Positional means it's triggered by changes in head position. And vertigo tells you it's that spinning sensation.
And what's actually happening in the ear with BPPV?
It's basically a mechanical issue. You have these tiny calcium carbonate crystals, otoconia, in a part of your inner ear. Sometimes, maybe due to age or a head injury, they get dislodged.
Like little rocks getting loose.
Kind of, yeah. And they can float into the semicircular canals, which are the tubes that sense head rotation.
And that causes problems.
Yes, because when you move your head in certain ways, like rolling over in bed, sitting up, looking up these loose crystals, move in the canal fluid and send false signals to your brain.
Saying you're moving when you're not, or moving differently.
Exactly. Your brain gets conflicting information, and the result is that sudden, brief, intense spinning.
But only when you move your head in those specific ways.
Typically, yes. And a key thing about BPPV is that between episodes, people usually feel perfectly fine.
Okay. What about Meniere's disease? That also affects the inner ear.
It does, but it's quite different. Meniere's is thought to involve an excess buildup of fluid, endolymph, in the inner ear.
More fluid pressure.
And this seems to cause these really intense, often debilitating attacks of vertigo that can last for hours, not just seconds or minutes like BPPV.
Hours. Wow. That sounds awful.
It can be. And it's often not just vertigo. People with Meniere's frequently experience other symptoms during an attack, like a feeling of fullness or pressure in one ear,
Okay.
ringing in the ear, which is tinnitus, and sometimes fluctuating hearing loss. Nausea and vomiting are also very common.
That sounds much more complex than BPPV.
It is, and the attacks can be quite unpredictable. Plus, people often feel completely exhausted afterwards.
How is Meniere's managed?
Often starts with lifestyle changes, particularly a low-salt diet, maybe reducing caffeine and alcohol. Sometimes diuretics are prescribed to help reduce fluid retention.
And for the attacks themselves.
Medications called vestibular suppressants can sometimes help reduce the severity during an acute attack.
Got it. And then there are inner ear infections.
Right, like vestibular neuritis and labyrinthitis. These usually involve inflammation, often thought to be caused by a virus.
Okay, what's the difference between them?
It's about which nerve is affected. The inner ear has nerves for balance, vestibular, and hearing, cochlear. Vestibular neuritis affects just the balance nerve.
So, mainly vertigo.
Primarily, yes. Sudden onset vertigo, often quite severe initially, lasting days potentially. Labyrinthitis is similar, but the inflammation affects both the balance and the hearing nerves.
Ah, so with labyrinthitis, you get hearing loss or changes too.
Exactly. Vertigo plus hearing symptoms points more towards labyrinthitis.
Are there other things that can cause vertigo, besides these main inner ear issues?
Oh, definitely. Though less common, things like an acoustic neuroma, a benign tumor on the nerve can cause it. Certain medications are known culprits.
Like what?
Some antibiotics, particularly aminoglycosides like gentamicin, some diuretics, even high doses of aspirin sometimes. Also, head injuries, stroke though, usually with other signs, multiple sclerosis, and something called vestibular migraine.
We should definitely come back to vestibular migraine.
We will. It's an important one.
Okay, so shifting gears a bit. Not all dizziness is spinning. What about that lightheaded, maybe going to faint feeling pre-syncope?
Right. That often points towards issues with blood flow to the brain, which can tie into the heart and circulatory system.
So dizziness could be a heart symptom.
It absolutely can. Sometimes it might be an early sign of heart disease. If arteries are narrowed, the heart might struggle to pump enough blood, especially during exertion.
Leading to dizziness.
Yes, and sometimes palpitations, that feeling of your heart racing or skipping beats. If dizziness happens along with palpitations, that's definitely something to get checked out.
And low blood pressure. That seems like a common one.
Very common. Hypotension or low blood pressure means less blood flow and therefore less oxygen getting to the brain. This can easily cause lightheadedness or feeling faint.
Especially when standing up quickly.
Precisely. That's called orthostatic hypotension. Your body normally adjusts blood pressure quickly when you stand, but if that adjustment is slow or insufficient, you can feel quite dizzy or faint for a moment.
Are there other heart or circulation issues linked to dizziness?
Sure. Things like a heart attack itself, significant blood loss, blood clots, severely clogged arteries, or arrhythmias, irregular heartbeats, can all reduce blood flow to the brain and cause dizziness.
Okay, so inner ear, heart. What are some other, maybe more everyday causes?
Well, dehydration is a really common one. Just not having enough fluid in your system can lower your blood volume and blood pressure.
Leading to that lightheaded feeling again.
Yep. Along with thirst, fatigue, maybe dark urine. Simple, but easily overlooked.
And medications. You mentioned some earlier causing vertigo.
Right, but many others can cause more general dizziness or lightheadedness as a side effect. Blood pressure medications, ironically, sometimes lower it too much. Antidepressants, anti-seizure drugs, sedatives. The list is quite long.
So always good to check the side effects list.
Definitely. If dizziness starts after beginning a new medication, it's worth discussing with your doctor.
What about low blood sugar?
Hypoglycemia, yes. Particularly relevant for people with diabetes, but can happen to others too. Your brain needs glucose for energy. Low sugar means dizziness, shakiness, sweating, confusion, hunger.
Makes sense. And good old motion sickness.
That conflict between what your eyes see and what your inner ear senses definitely causes dizziness, often with nausea. Cars, boats, planes, even VR headsets for some people.
Right. And head injuries, like concussions.
Yes, dizziness is a very common symptom after a concussion or any traumatic brain injury, along with headache, nausea, maybe ringing in the ears, vision changes, confusion. Any suspected concussion needs medical evaluation.
It's also interesting that anxiety and stress can manifest as dizziness.
It is, and the connection isn't fully understood, but it's quite real for many people. It might involve the interplay between brain areas processing emotion and those processing balance signals. High stress levels can definitely make you feel unsteady or lightheaded.
Okay. Then there are a couple of potentially more serious causes we should mention. Carbon monoxide.
Yes, absolutely crucial to be aware of. Carbon monoxide poisoning is a silent killer. Dizziness is a key symptom, often with headache, weakness, nausea, confusion, even chest pain. If you suspect it, get out into fresh air immediately and call for emergency help.
And low iron levels. Anemia.
Iron deficiency anemia, yes. Iron is needed for your red blood cells to carry oxygen. Not enough iron means less oxygen delivery to the brain and tissues.
Causing dizziness.
Along with fatigue, weakness, shortness of breath, cold hands and feet, difficulty concentrating, sometimes pale skin or headaches.
What causes low iron?
Various things, not enough iron in the diet, problems absorbing iron, blood loss like heavy periods or internal bleeding. Needs investigation.
Okay. Now, what about dizziness in older adults? Sometimes it seems harder to pin down a specific cause.
That's a really important area. We often see older individuals with persistent, kind of vague dizziness and imbalance, but standard hearing and vestibular tests are normal.
So what could be going on?
There's growing focus on something called cerebral small vessel disease, or CSVD.
Small vessel disease in the brain.
Yes. These are subtle changes in the brain's white matter, visible on MRI scans, often related to aging and vascular risk factors like high blood pressure.
And how does that connect to dizziness?
Well, studies show a link between the amount of CSVD and balance problems or falls. The theory is that these changes might subtly disrupt how the brain processes balance information from the inner ear and other senses. Also, these small vessel changes might affect blood flow regulation.
Leading to that postural lightheadedness again.
Potentially, yes, contributing to that feeling of unsteadiness, especially when upright or moving. It's an area of active research, but likely a factor in many cases of unexplained dizziness in the elderly.
Okay, let's circle back to vestibular migraine. You mentioned it earlier. How common is that link?
It's surprisingly common. Many people with a history of migraine headaches also experience episodes of vestibular symptoms.
Like vertigo?
Yes, vertigo, or sometimes just dizziness, imbalance, motion sensitivity. These episodes can happen with or without a headache at the same time.
So the dizziness is the migraine, essentially, or part of it.
Exactly. It's considered a type of migraine aura or equivalent. People with vestibular migraine often have other migraine features too, like sensitivity to light or sound, nausea, even during the dizzy spells.
Are there typical triggers?
Similar to regular migraine triggers for many stress, lack of sleep, certain foods, hormonal changes, but also head motion itself or visually busy environments can sometimes trigger an episode in these individuals.
Interesting. Any other clues?
A history of motion sickness from childhood is quite common, and sometimes during an eye exam, they might feel uncomfortable looking upwards. There seems to be some altered connection between the visual and vestibular systems.
How's it treated? Like regular migraines?
Pretty much, yes. Identifying and avoiding triggers is key. Lifestyle factors like good sleep, exercise, stress management help. Then there are abortive medications for acute attacks and preventive medications like beta blockers, some antidepressants, anti-seizure drugs, CGRP inhibitors to reduce frequency. Vestibular rehab can also be useful.
Okay. Now, another term I've seen is PPPD. Persistent postural perceptual dizziness.
Yes, PPPD. This is a chronic condition. It's characterized by persistent dizziness or unsteadiness, usually present most days.
Persistent. Okay. Not just episodes.
Generally not distinct episodes like BPPV or Meniere is more of a constant background feeling. And it's typically worse when upright, standing, or walking, and often exacerbated by complex visual environment.
Like supermarkets or crowds.
Exactly. Or scrolling on a computer, watching action movies, things with lots of visual motion or detail.
What causes PPPD? Does it just start out of the blue?
Interestingly, it often follows some kind of acute event that initially caused dizziness or disturbed balance.
Like what?
Like an episode of BPPV or vestibular neuritis or a concussion or even a panic attack or period of high anxiety.
So the original problem might resolve, but the dizziness sticks around.
That's the idea. The theory is that the initial event triggers changes in how the brain processes balance and spatial information, and these changes persist. There might be an over-reliance on visual information for balance, heightened anxiety about balance, and hypervigilance to normal body sensations.
Almost like the brain gets stuck in a high alert state about balance.
That's a good way to think about it. And interestingly, sometimes people with PPTD might actually perform better on balance tests as if they're distracted, suggesting a cognitive or attentional component.
How do you treat something like that?
It usually requires a multi-pronged approach. Vestibular rehabilitation is key, but specifically tailored to help reduce visual dependence and desensitize to provocative movements or environments. Medications, often SSRIs or SNRIs like sertraline or venlafaxine, can be helpful, probably by modulating anxiety and sensory processing. And cognitive behavioral therapy, CBT, can address the anxiety, avoidance behaviors, and hypervigilance.
Wow, that sounds challenging but treatable.
It can be, but with the right combination of therapies, many people find significant improvement.
Okay, one last critical link. Dizziness and stroke. This is obviously a major concern.
It is, and the tricky part is that sometimes a stroke affecting the balance centers in the cerebellum or brainstem can present only with vertigo or dizziness without the classic signs like facial droop or arm weakness.
So it could look like an inner ear problem.
It could mimic one, yes, especially in the acute phase. This is where differentiating central stroke causes from peripheral inner ear causes of acute vertigo is so important in places like the emergency room.
How do clinicians tell the difference quickly?
There's a very valuable bedside examination technique called the HINTS exam.
HINTS.
Yes, it stands for Head Impulse Nystagmus Test of Skew. It's a series of 3 eye movement tests that, when performed correctly in a patient with ongoing acute vertigo, can be remarkably accurate at identifying stroke.
Can you briefly explain what each part looks for?
Sure. The head impulse test checks the vestibulo-ocular reflex. If it's normal during acute vertigo, that's actually more concerning for a central cause like stroke. An abnormal test with a corrective eye movement, a saccade, points more to a peripheral inner ear problem.
Okay, so normal is bad in this test.
In the context of acute continuous vertigo, yes, a normal head impulse test is a red flag for stroke. Then nystagmus, that's the involuntary eye flicking. Certain patterns like nystagmus that changes direction when the patient looks left versus right, or purely vertical or torsional nystagmus, suggest a central cause. Typical peripheral nystagmus is usually horizontal and beats in one direction.
Got it. And the test of skew.
That looks for vertical misalignment of the eyes. If you cover one eye and then uncover it and it has to move vertically to realign, that skew deviation is another sign pointing towards a central problem.
So the HINTS exam helps rapidly sort out potentially dangerous causes.
Exactly. There's also HINTS Plus, which adds assessment of hearing loss. New hearing loss with acute vertigo often points to a peripheral labyrinthitis, or sometimes a specific type of stroke affecting the inner ear artery. Widespread use of HINTS has significantly improved the diagnosis of stroke in patients presenting with dizziness.
That's a really important advancement. Okay, so we've covered a lot of ground on causes. Let's talk about recent developments in evaluation and treatment more generally. You mentioned the titrate approach, focusing on timing and triggers.
Yes, that shift towards prioritizing the patient's history based on timing and triggers, rather than just trying to get them to label the sensation, really helps guide the whole process. It helps categorize the dizziness early on. Is it triggered episodic, spontaneous episodic, or continuous?
And that categorization then leads to a more targeted exam.
Precisely. So the physical exam will still include fundamentals like orthostatic blood pressure checks, lying, sitting, standing, a full cardiac and neurological assessment. But the focus sharpens.
How so?
Well, if the history suggests triggered episodic vertigo, you'd prioritize doing the Dix-Hallpike maneuver very carefully, looking for that characteristic BPPV response. If it's acute continuous vertigo, the HINTS exam becomes absolutely crucial. You'll also carefully assess gait, maybe do a Romberg test, standing with eyes open then closed, to check balance. Observing the eyes for nystagmus, its direction, how it changes with gaze is always key.
And if the bedside exam isn't conclusive,
Then more specialized vestibular testing might be needed. Things like video nystagmography, VNG, or electronystagmography, ENG, which record eye movements in response to various stimuli.
like tracking lights or having warm, cool water or air put in the ear canal.
Exactly. Also, rotational chair testing, where the patient sits in a motorized chair that moves in precise ways, or posturography, which measures balance on a moving platform.
So technology helps get a deeper look.
It can quantify the function of different parts of the vestibular system when needed.
What about treatment updates? For BPPV, is it still mainly those repositioning maneuvers?
Yes, absolutely. Canalith repositioning procedures, like the Epley maneuver, remain the gold standard. They are highly effective, often curative in just 1 or 2 sessions.
Done by a trained professional.
Ideally, yes. Though patients can sometimes be taught home exercises like the Brandt-Daroff exercises for management, importantly, vestibular suppressant medications like meclizine or dimenhydrinate are generally not recommended for BPPV because they can hinder the brain's natural compensation process.
Okay. And for Meniere's, anything new there?
Management still focuses on lifestyle, low salt, and diuretics first line. For refractory cases, injections through the eardrum, transympanomic injections of steroids, or sometimes low-dose gentamicin, an antibiotic that can reduce inner ear function, are used more often now before considering more invasive surgery. Vestibular suppressants are just for acute attacks.
What about vestibular neuritis recovery?
Supportive care initially, anti-nausea meds may be short-term vestibular suppressants, but the main treatment is vestibular rehabilitation therapy exercises to help the brain adapt and compensate. There was hope corticosteroids might help, but evidence is weak for routine use. Antivirals aren't effective.
And for vestibular migraine and PPPD, treatment seems more complex.
It is, reflecting the complex nature of the conditions. For vestibular migraine, it's trigger avoidance, lifestyle, plus migraine-specific preventive and abortive meds. For PPPD, it's that combination of specialized vestibular rehab, reducing visual dependence, habituation, medications, often NRIs, and CBT. It requires a tailored, multimodal approach.
And for dizziness from orthostatic hypotension.
Lifestyle, first increase fluids, maybe salt, compression stockings, move slowly when changing posture. Reviewing medications to see if any are contributing is crucial. If needed, medications like midodrine or fludrocortisone can help raise blood pressure. And in very rare, severe cases of inner ear disorders causing intractable vertigo, surgical options like labyrinthectomy, removing inner ear function, or nerve sections exist, but they're reserved for extreme situations.
It really is encouraging to see how understanding and treatment options are evolving across the board.
Definitely. While dizziness can be unsettling, the ability to diagnose the specific cause and tailor treatment has improved significantly.
So for anyone listening, the takeaway seems to be, pay attention to the specifics. How does it feel? When does it happen? What makes it better or worse?
Absolutely. That information is gold for your doctor. Don't just say I'm dizzy, give them the details.
And know that tools like the HINTS exam for acute vertigo and a better understanding of conditions like vestibular migraine and PPPD are really making a difference.
Most causes of dizziness can be managed effectively once properly diagnosed.
So seeking a thorough medical evaluation if you have persistent or worrying dizziness is definitely the key step.
Couldn't agree more.
Right. So to leave you with something to think about, given this incredibly complex web of systems involved in balance, eyes, ears, brain, nerves, even blood pressure, what other, maybe less obvious factors in our lives or health might subtly influence how steady we feel day to day? Something to ponder.